we're going to talk a little bit about the change to the LVAD protocol. So fairly substantial change as far as language, centering really more about the patient than about the device. So Mo, you want to talk about that a little bit?
Yeah, so I think this was kind of forced upon us because there's a whole new generation of LVADs out there, and as technology goes, it's going to continue to evolve. So in the past, when we introduced the LVAD, we focused a lot on device and device failure, but the machines are now pretty sophisticated. They actually basically talk to you and will tell you what the issues are. So couple of things have come to light. One is we have a lot of patients with LVAD. Some of them are actually being bridged to transplant, but many of them are actually what we call the destination therapy. This is going to be the way they survive with their heart failure for the rest of their remaining lives, however long that may be. So LVADs basically are a left ventricle assist device, and essentially most LVADs take blood from the left ventricle and pump it into the aorta, and they basically replace your left ventricle for people who have bad congestive heart failures. So in this protocol, we kind of go through a step-by-step assessment of this patient. Although they have technology, most of the times when they call you, the technology is working fine. Remember that LVAD patients are at risk for a number of other things, and you got to keep the whole picture in mind. The big things that they're at risk for is, one, they have lines going into their body, so infection is key. So they're high risk for infection, and many of them are septic. So always have that in the back of your mind. Secondly is that the left ventricle in these patients really needs volume, and so if they don't have enough volume for any reason, they've had some diarrhea, they didn't drink enough, and they're not having enough volume, the pump will stop working and basically not work as well. And so that is often why they get syncope and they'll pass out. So this is really important to make sure that their volume status is properly assessed and if necessarily supported. They're all on anticoagulants, so they're at risk for bleeding. But unfortunately also, because the blood is being pushed through a pump, they're also at risk for getting basically thrombosis at times, and so they can also get clots if they're not properly anticoagulated, and so then they can get strokes from this. And then lastly, all of these folks have heart failure. Heart failure is a risk for arrhythmias, and so many of these patients can be in VF, VTAC, all sorts of arrhythmias, and so be prepared to be managing and thinking about arrhythmias as well. So there's a device issue, but don't forget the patient issue. In terms of patient care, basically remember that most of today's devices are continuous flow devices, so you will not feel a pulse. In general, you can pick up circulation in these patients indirectly. Either you need to use a Doppler signal if you have one of those available, or you can try to use end-tidal CO2 as a surrogate marker for perfusion. You can still try your cuff and your blood pressure cuff, and sometimes if there's some intrinsic left ventricular function still occurring and there's some pump activity, you might see a blood pressure, but really the Doppler is the best way to do that. And lastly, in cases where you don't have a Doppler, don't have the end-tidal CO2, look for clinical signs of perfusion. Mentation is a good one. Skin circulation is another good one as well. Because of their fluid responsiveness needs and their need, it's important to get an IV and basically make sure you at least consider a fluid challenge in almost all of these patients who you see, because they will benefit from at least a 500 cc fluid bolus and potentially more. We also want you to always contact their LVAD coordinator for the specific hospital that they're attached with. So there are 3 LVAD centers in the region: Kaiser Sunnyside, Portland St. Vincent's, and then OHSU. Each of them has a coordinator team on call. Some you can contact directly via cell phone. Others will basically, you'll need to reach to the hospital operator, but they will respond pretty quickly and they can troubleshoot with you what's going on. Usually there's an alarm that goes on. It's a low flow alarm. Typically everything else is working fine, and then you look at the patient to figure out why they have a low flow alarm. Occasionally, however, there's a battery alarm or there's a controller alarm, and that's what they'll work with you. So having the advantage of the LVAD coordinator, since they deal with these patients on a daily basis, they know what's going on with the patient, and they'll be able to guide you through what steps to go through, and then potentially recommend some options. If necessary, online medical is very helpful as well. And try to contact the LVAD coordinator with the specific institution, and each of these patients knows where their LVAD was placed, and so remember that. Another key thing is that each of these patients has a backup controller that's actually programmed specifically for them. That should go with them, and they have a little bag that they carry. Make sure you transport that with them so that if there's any issues with the controller, they can change them to the one that's pre-programmed and pre-specified for them. Every heart is unique, and the settings are basically set, and so everybody gets a controller implanted, that's with the implanted device, but they have a backup controller that's actually pre-programmed. Don't worry about your cardiac monitor. You can put it on and you can get an EKG as well. Almost all these patients have an AICD/pacemaker in place, all right? So if you have to do anything with them, you may need to turn those devices off if they're firing inappropriately, but then you need to be able to put your pads appropriately, not over the devices, so you can use them as backups. Finally, the big thing that has come up, and sorry, I should say before I go to the final comment, you can use all your ALS medications as appropriate. A big question has come up is, can I do CPR? We used to say no, but there's now a handful of cases where CPR has been done in dire emergencies where you basically checked everything else, and that's something that we want you to actually contact and discuss with the LVAD coordinator. In general, the answer is going to be no, but if everything has been exhausted and that's the only thing left, that's a discussion you will have likely with the LVAD coordinator, plus or minus online medical, as to whether you should do compressions or not. But my hope is that most of the times it's not the device, it's the patient issue you need to focus in on. So remember those big things. Remember infection, volume depletion, stroke, bleeding, and dysrhythmias. These are things that should be in the front of your minds as you go in to assess an LVAD patient. Don't just be focused on the fancy technology. That's where we get ourselves into trouble.
Okay, thank you. So it's, again, fairly substantial update, so please take time to read through it. And again, if you have any questions, please contact your agency's training officer. Thanks again for watching.